Hello everyone, welcome back to my channel. For today's video guys, I'm going to share the approach of endorsement we have dito sa ICU sa Hamad. I know na ito ay majority alam na and it's basic for everybody. And alam natin na may iba-ibang way on how to do our endorsements. But for me, ginagamit ko talaga siya kasi for the past 5 years, dito ako nag-survive. Dito ako natuto for in a daily basis na duty. So, eto, hindi ko sinasabi na ang ICU ay sobrang mahirap o sobrang dali. Ang buhay sa ICU, sometimes balance, sometimes mabigat. Pero hindi ko din na-discourage ang mga aspiring RNs, hindi lang dito sa Qatar, but to all nurses all over the world. Kasi ang ICU kasi, naririnig natin sobrang hirap daw para sa matatalino, para sa magagaling. Pero guys, sinasabi ko, hindi lahat dapat ang mindset natin para dyan. Kasi working in an ICU setup, everyday is continuous learning. Lahat ay natututunan, hindi man sa mabilisang paraan, pero it takes time para ikaw ay maging isang tunay at batikang skilled ICU nurse. Though may mga experiences tayo, like from previous hospital, previous work, pero hanggat wala ka sa ICU, hindi mo mararanasan o hindi mo ma-experience yung legal na bakbakan. So, I'm going to share to you guys yung ginagamit kong endorsement approach or way para mas mapabilis at saka kahit simple lang siya, precise pa rin siya. Kasi yung iba, nagdidepende din kasi sa doctors. Yung doctors, sinasabi ABCDE approach or hanggang J yun. Pero majority ng doctors dito sa Qatar, nagpapa-history sila, tapos nagpapa-system by system. So pag sinabi ng system by system, yun yung CNS, CVS, Respi, and so on and so forth. So to all aspiring nurses or newly hired nurses, hindi lang dito sa Qatar, but to all nurses in the world na gustong mag-work in ICU setup, I hope na you can get a little bit, or not just few, but you can grasp the idea and the setup na you can apply in a daily basis while working in an ICU setup. So let's begin! So first guys, I'm going to share yung ginagawa ko talaga or ginagawa namin dito sa Qatar, sa ICU namin. Usually, we do head-to-toe the assessment. So parang ganun lang din yung pag i-endorse mo during the multidisciplinary with the doctor's rounds. So initially, i-share ko kung paano yung sa amin dito. At least, you can grasp the idea and the thought na magagamit mo siya in a way. So first namin ini-endorse ay ang patient's name, full name. Kasi dito sa Middle East, guys, uso yung same na mga pangalan, apelyido, pero nagkakaiba lang sila sa healthcare number, yung age ni patient, yung gender. Kasi dito, mostly, parang sila, first cousin, like that, relatives. So, nothing to worry about naman, basta tama lang yung patient identification natin. So aside from that, yung kung meron bang allergy si patient, yun yung isa sa mahalaga. Kasi that one, dyan tayo magmamatter or magdidepende especially sa antibiotics, sa foods and medications natin. And the next one is kung may previous history si patient, like may family background for any comorbidities, hypertension, diabetes, heart disease, at kung ano pa. So after that one guys, ito na yung present history illness ni patient. Kung kailan si patient na-admit, anong reason bakit siya na-admit, at saka kung saan siya initially na-receive, like for example in ED or emergency department. Tapos at initial assessment ni patient, i-admit siya ngayon sa ward for example. So parang yung course of admission ni patient, you need to endorse. So aside from that, gumagawa din kami ng history, yung sa ginagawa namin ng book or like manual para dun ilista yung mga nangyari kay patient. So for example, is sa patient is nag-RRT, rapid response team activation. Kunwari si patient ay increase yung heart rate, nag-increase yung respiratory rate, high blood pressure. So usually, si patient ay ililipat sa ICU. So another transition na naman, another entry ng kanyang admission, mag-start na naman siya sa ICU. So in short, you need to endorse yung pinaka-history ni patient. And then afterwards, i-endorse na namin ngayon yung system by system. So mag-umpisa kami sa CNS, yung Central Nervous System. Dito papasok, kunwari for example, si patient intubated. So sasabihin namin yung sedated si patient, paralyzed. So meron tayong iba-ibang sedations. So for example, we have fentanyl, midazolam, propofol. Depende yun sa order ng doctor or yung preference na kung for ilang days lang ba si patient i-intubate or ilang days lang siya ma-extubate. So depende din yun sa progress or pag-improve ni patient sa condition niya. And then for example, meron din tayong paralytic agent. So endorse din natin siya. Usually yun yung rocuronium or si satracolium. So dito din i-endorse natin yung RAS. So ang RAS natin guys is the Richmond Agitation Sedation Scale. Meron siyang criteria, numbers, may positive and may negative. Pero yung positive part, yun yung mga yung agitation, tapos pag sa negative naman, yun yung mga light sedation, moderate sedation, deep sedation, tapos mga unarousable. Usually kasi dyan din magmamatter yung doctor's order for the sedations. So for example, sinabi nilang negative 2 lang yung gusto nilang RAS. So under siya, moderate sedation. So ititrate mo ngayon yung sedations ni patient according to the present RAS score. At saka aside from that, meron din tayong BIS monitoring, yung bispectral monitoring. Usually nilalagay yan kapag si patient ay sedated. So for example, may paralytic agent din si patient, lalagyan din natin siya ng TOF, yung train of 4. So may initial time kukunin doon, yung 2 to 3 twitches, tapos after the initial, dun na yung rate natin magdedepende. And you will monitor it according to the protocol or kung ano yung order ni doctor. And aside from that, kung febrile ba si patient or afebrile, and then especially na din yung yung sa pupils, kung reactive, non-reactive, fixed na ba yan, or unresponsive, or no reaction at all. Kasi kapag fixed, guys, it's alarming to the healthcare provider. Not just for us nurses, pati na din sa doctor. Usually si doctor magpapastat CT scan yung mga yan sa head po. So after that, proceed na po tayo sa cardiovascular. So CVS, cardiovascular system, dito naman papasok yung more on sa puso lang. For example, si patient may inotropes, i-endorse po natin yun. Mahalaga po yung rate no, lalo na yung pong noradrenaline, yung rate niya, tapos ilan ang remaining. Kasi mahalaga yun kasi pag wala ng laman yung syringes or kung anumang ginamit niyo na bag, mag-hypo si patient. So magkakaroon na naman ng problema. So dito din papasok kung kailan nagkaroon si patient, for example, ng to the echo, kung ilan yung ejection fraction niya, nag-undergo ba siya ng procedure, yung mga stress test, tapos yung TEE, transesophageal echocardiography, nag-PCI ba si patient, or nag-heart transplant. So, ganun lang. Tapos, next na is yung respiratory naman. Ang respiratory, usually, sinasabi namin, for example, day 2, intubated si patient, tapos yung ET size, lip level, mahalaga yung lip level, guys. Kasi, yan yung palatandaan na kung ano yung level na intubate si patient. Tapos, usually, during x-rays, yun yung palatandaan kung nasa carina or above the carina ba siya, need or hindi na siya i-adjust. Tapos, yung last chest x-ray, yung settings ng neck vent, usually, marami ditong settings ng patient, depende sa kanilang response. Meron din tayo ditong meron iba-ibang settings. Hindi katulad siya sa Philippines na usually 3 lang. Dito kasi ang gumagalaw lang nun, majority is the respiratory therapist, yung RT. So they will monitor every 4 hours per shift, at saka kung may plan ba for extubation, kung may for changing ng settings. Usually kapag si patient is ARDS, need na i-prone, yun, kailangan yun magkaroon ng lung recruitment. So hahanapin yung pasok sa patient na PEEP, yung FiO2, tapos yung rate ni patient. So after that, proceed na tayo sa gastrointestinal or GI. Usually dito papasok yung formula. Yung NGT formula ni patient, depende yun sa orders. Kung diabetic formula, kung diabetic si patient, pulmonary formula, renal formula, tapos depende din yung rate doon kasi dito meron po tayong nutrition protocol. So yung nutrition protocol na yun, I will discuss in the next videos kasi kailangan mo siya i-elaborate para mas maintindihan yung pinaka-protocol itself kasi it usually used din sa age, sa weight ni patient, yung height ni patient, yung ideal body weight, and the body mass index. So dito din papasok kung kailan si patient nagdumi, last bowel motion, nag-iniba ba si patient, colostomy, tapos kung kailan siya huli nag-chest x-ray ng abdomen, kung if necessary lang naman. Tapos, genitourinary, dito naman papasok kung may Foley's catheter si patient, kung passing adequate urine output ba every hour, kung may furosemide ba tayo per day or once daily, BID, IV or tablet, and then dito din papasok yung positive balance for the past 24 hours, kung negative ba or positive, and mahalaga din po yung cumulative balance. Yung cumulative balance kasi, it's in the system. You can open it in iAware. Yun yung aming ginagamit na system dito. So you can check there for the past 7 days kung negative ba or positive balance si patient. Tapos, after which, endocrine-wise, kung meron ba si patient RBS monitoring, kung every hour ba. Tapos, meron din tayong protocol if ang patient is having insulin infusion. Ang protocol na yun, I will elaborate din sa next videos. Usually kasi, it will take time for the adjustments of the rates. Kasi meron tayong algorithm 1 or 2. Kasi, depending on if the patient has steroids ng medications niya. So, meron din tayong steroids nga, yung nabanggit ko, kung meron siya every 8 hours or BID, tablet or IV. So aside from that, kung meron tayong insulin sliding scale, so yung insulin sliding scale na yun, usually 3 times a day yun. So whatever the result, ibibase lang doon yung units na ibibigay mo sa patient. Tapos after nun, ay kung may glargine din ba si patient, which is a long-acting insulin na it will take tomorrow pa yung last effect ng iba. Tapos usually once daily lang naman siya, subcutaneous at night. Tapos after which is punta tayo sa DVT prophylaxis. If si patient is may renal failure, usually ang doctors refer yan to renal service, and usually yung mga prophylaxis nila is the heparin sub-Q. So kung prophylaxis lang as dahil na admit si patient and intubated, usually kasi prone din sila sa mga embolism. So usually or normally, ang prophylaxis ni patient ay mga enoxaparin. So sub-Q din po siya, depending on the weight din ni patient and kung therapeutic level din. Yung therapeutic level natin guys, usually ginagamit din siya if the patient has pulmoembo. Depende din yun sa weight ni patient. So kung ano yung management na gusto nila doctor gamitin or magpapa-heparin infusion sila. So yung heparin infusion, may protocol din po tayo niyan. So for the next videos, I need to tackle din para meron tayong makuha lang ng graphs or maging aware lang din po tayo niyan. So as you have from previous or may na-encounter kayong ganyang protocol, mas ma-enhance lang po. And then next po is the peptic ulcer disease prophylaxis. Ito yung isa sa mahalaga dahil si patient is prone magkaroon ng mga ulcers. So usually binibigyan sila ng tablets kung wala naman GI bleeding. So kasi kung may GI bleeding yan, magpapastart na sila doctor ng pantoprazole infusion. So kung wala is regular lang, daily basis. Yun yung mga esomeprazole tablet, pantoprazole. Pero yung pantoprazole kasi, hindi natin siya nakakrush. Yan ang isa sa sinasabi ng pharmacist na hindi nakakrush. So we need to shift, for example, to esomeprazole or kung ano pang PPI available na walang contraindication or drug interaction sa other medications ni patient. And then the next one is the ID, so which is the infectious disease, or kung meron na tayong antibiotics. Ang pinakamahalaga dito guys is kung kailan siya na-start. Kasi magtatanong si doctor, how many days na siya today. So bibilangin mo siya, kung hindi na-endorse siya, naka-endorse mo, bibilangin mo lang siya sa more summary. So makikita mo yung day 1, day 2, so kung ilang day na siya today. Kasi mahalaga yan, kasi for example, nagkaroon si patient ng fever, the doctor might change the antibiotics to stronger ones, or magpapa-cultures sila ulit, blood cultures, urine culture, tapos ETT culture kung intubated si patient. Tapos, aside from that is kung ano yung mga antibiotics na completed na ni patient. Tapos, regarding with that one din, kung may mga cultures na nagawa, for example, yung blood culture may results, so like Candida species, or positive si patient for MDRO. So, nandun din yung, yung sensitivity. So, kung ano yung sensitivity ni patient to these medications, usually yun yung ibibigay na medication or antibiotic to the patient from the doctor's order. Tapos after that, yung lines. Yung lines natin, mahalaga. Like for example, central line. Kasi meron po tayong central line bundles. And kung ilang days na siya. For example, 20 days na siya and the patient has or having a fever episode. So, probably the doctor will order, or as a nurse, as the primary nurse for this patient, you have the authority to suggest to the doctor what is the best for this one. And then if the patient is in ICU or intubated, so we prevent punctures. So usually, admission pa lang, lalagyan na yan ng arterial line kasi ang arterial line guys, doon na lahat kukunin yung dugo. For example, for blood culture, yung daily lab works, tapos yung ABG. So, ang ABG guys, tayo ang kumukuha kapag ICU nurse. Pero if it's related for the breathing of the patient, si RT, usually na gumagawa nun. They're responsible for that part naman. So, if not related to the breathing of the patient, tayo mismo ang kukuha nun. Tayo din magra-run. We have the access codes. So, tatype mo lang. So, for the ABG, ang mahalaga doon is the pH, the CO2, the PO2, the bicarbonate, lactate, and the PF ratio. So, PF ratio guys, another topic na naman yun para ma-elaborate. And aside from that, the peripheral lines, kung ilang days na din siya, usually kasi we have policy or the protocol 4 days for change. But for now, as COVID pandemic, usually kapag wala pang fever sa patient, ina-extend namin to 1 week and we can remove then insert a new line. Then aside from that guys, yung medications ni patient, as much as we can, dapat nakakopya tayo or nakalagay yun sa ibang paper page sa likod man or kasi meron kang receiving copy. So, para pag tinanong ka ni Dr. what are the medications of the patient, hindi ka na mag-open ng system kasi yung system, usually, kapag peak hours, hindi siya mag-open. Matagal. Tapos, aside from that guys, is kung ano yung suggestions yung for the patient to the doctor. Kasi, for example, yung sa labs, mababa ang sodium. Or, for example na lang is hypernatremia. So, sabi mo si doctor, magsasuggest ng distilled water, flashes every 6 hours. Kasi usually, kung mataas, 148, 150, kailangan si patient magkaroon na para ma-flush yun. Tapos, pag mababa ang magnesium, phosphorus, calcium. So, i-suggest ba naman doktor kung okay po ba if we can start corrections for magnesium, calcium, phosphorus. Kasi once na ordered na yan, it depends din pala kay doctor with the potassium kasi we have solution. We can give it directly to the NGT na patient. So kung wala, IV, kung mababa talaga, like 3.5 lang millimoles per liter, yun, IV na ang ibibigay kay patient. So, mas okay yun, better. Pero may mga doses kasi din yun, depending on the concentrations, na bawal for the Pereline kasi sobrang hapdi nun guys, potassium chloride. So usually kapag ang patient kasi may central line, so sa central line access natin sa iraran to prevent yung mga phlebitis sa perilines ni patient. And then aside from that, magdi-discuss yung doctor sa'yo what are the plans kasi usually before the rounds, nakapagbasa na sila ng systems ni patient. And then, if the patient then is for procedure, usually, yung mga kailangan mong gawin, like in procedures, tapos i-ready mo si patient. Tapos si doctor, after the nurse-doctor interaction, ang tawag namin dyan guys is multidisciplinary rounds. So after that one, papasok na kayo ngayon sa patient's room. So yung doctor, mag-a-assess niya ng doctor, papakinggan niya yung mga breath sounds, yung sa abdomen, tapos kung any issues towards kay patient. So, sobrang ikli lang guys. Usually, hindi mo naman kailangan talaga i-write down lahat. Just write down the important points na kailangan i-ask ni doctors. So, for this case guys, since lang siya, CNS head to toe ang assessment, kumbaga, same lang din yan ng pag-endorse mo sa ka-endorse mo. So, mas mabilis lang siya, maintindihan yun agad, and hindi pa ulit-ulit yung tanungan. Kasi, for us, nagmamatter din kasi yung time ng bus. Kasi, maiiwan ka ng bus since it's free shuttle bus for us. So, we don't need to spend that much money for the Uber kasi medyo mahal, guys. So, for that part, guys, yung ka-endorse mo naman, usually gagawa yun ng sarili nilang paper, pero wala ka namang paproblemahin kasi ang mas mahalaga kasi you endorse the significant details sa ka-endorse mo. So after that, gagawa ka lang ng patient handoff yung mga entries mo kung ano yung pending mo na i-endorse kay patient. So kung morning shift ka, usually gagawa ka ngayon ng handing off like daily lab works, kung for chest x-ray tomorrow, and then if the patient has inotropes, sabihin mo lang na watch out for hypotension, titrate noradrenaline accordingly, tapos turning every 2 sides kasi isa yan sa mahalaga as part of the quality. So after that one, endorse mo lang yung pangalan mo sa pinaka lower part and kung sino yung mag-receive na pangalan. So after that one, usually talaga pumapasok kami sa patient's room. So mag-a-assess na naman kami or i-endorse ko, for example, the rate ng mga settings or rate ng ating inotropes, sedations, kasi dapat tama siya sa mga na-endorse mo sa incoming shift or mag-reflect din siya doon sa mismo mga infusion pumps natin. Tapos yung NGT, yung feeding formula, yung Foley's catheter, yung level ng ATT, tapos yung settings ng ventilator, mahalaga din yun. So after nun, tapos na. So, wala ka nang problemahin, uwi ka, tutulog, tapos routine. So, kung ano lang yung mga unexpected events na nangyayari, you will document it sa nurse's notes. So, for us kasi, we don't do redundant na kasi na ginagawa kasi may per systems, yung documentation tool natin, hindi na natin sasabihin ulit doon sa nurse's notes. Pero ako, nag-jot down notes lang ako doon, like important matters. For example, yung patient hindi intubated pagdating, tapos after some time na si patient is nag-deteriorate, so you need to document na, for example, si patient nag-shortness of breath, tachycardic, tachypneic, tapos nag-hypotension. So those are the points na kailangan mo i-document kung anong nangyari. Tapos On the following day, usually, same nurse, continuity of care lang. So, the more na kilala mo yung patient, the more mo mabilis lang ma-endorse to the next shift. And aside from that, not necessarily na bit-bit mo lagi yung endorsement paper mo. Kasi as a staff, ICU staff, nasa mind mo na din sila. Kumbaga, kilala mo yung patient mo at hindi ka bukas ng system mo para lang i-open and to see informations na tinatanong ni doctor. So with this kind of endorsement approach, usually known siya to everyone. Known siya sa ICU setup. Pero why I'm sharing this to you guys, kasi yung mga nagta-transition from ward, nagpantang ICU, it's very essential, guys. Kasi for sure mga ngapa talaga. Kasi they need a transition. Kasi it's a new parang journey, challenging everyday kasi siya. So, hindi ka naman problema kasi you have your preceptors. Your preceptors are trained. So, you don't need to worry. But, ang mahalaga sa'yo, guys, is you have to grasp everything. You need to ask questions. You are in doubt. And, hindi ka dapat yung attitude, isa yan sa pinakamahalaga. Attitude, your eagerness to learn, your willingness to accept criticisms, and your progress towards everything. Kasi ako, as ICU staff, hindi ako dumaan sa parang mabilisan or I grasp everything. Kasi hindi lahat ng nasa theory ay magagamit mo in the clinical practice because there are a bit difference. So kumbaga, you will learn from time to time hanggang sa masanay ka. Kumbaga, you have the knowledge like residents, guys. Kumbaga, you know how to deal with especially problems or kung anong ma-encounter mo. You know what interventions to do. Like for example, yung nag-seizure, yung mga managements. So, kung ano pa. Kasi you are trained enough to be and skilled, experienced, and competent ICU nurse. So guys, I hope you enjoy. I hope you learned something. I hope you can apply this when you have your clinical exposure sa mga bago. And for the experienced ICU staffs na, nothing is to worry naman if you will adopt this kind of endorsement kasi majority naman gumagamit nito. Pero I'm just sharing this to our beloved aspiring incoming nurses or newly joined. Thank you for watching, guys. Don't forget to subscribe and click the bell button. Bye-bye.